All right, everybody, and welcome to another episode of the Future Ear Radio Podcast. I am thrilled to be joined today by Dr. Lindsey Jorgensen. Lindsey, thanks for coming on the show.
It's so exciting to be here. I always love talking to you and talking to audiologists and talking to other professionals.
Awesome. Well, thanks for coming on today. I'm really looking forward to our conversation. So why don't we start at the beginning, give you an opportunity to share a little bit about who you are. Go back to the start. Where did the whole motivation for pursuing audiology come from?
So I grew up in Boise, and both of my parents are in public school education. My dad's a principal. My mom was a director of special ed. So I grew up kind of being in a situation where caring about others and how giving back to others was really important to me. But I also realized really quickly I didn't want to be in education. And so then I went to college at the University of Washington and dabbled in different areas of medicine. I thought for a while I was going to be a neurosurgeon. I went to my first neurosurgery, and that surgery was not successful. And I really struggled with that because I thought that was the path I was going to go. I then ended up in a research laboratory looking at outer hair cell regeneration. And I realized that I really enjoyed kind of pushing those limits of our current knowledge, but I really wanted to work with people. Right. I was doing animal research and I realized that did not internally fulfill me. And so that's how I found the profession of audiology. So I'm not one of the ones who thought that they were going to be a speech language pathologist and became an audiologist. But so my background was a little bit more in that kind of neurology background. And so then I got a degree from the University of Washington, and the chair at the University of Washington said, I think you need to go to Pittsburgh and work with the people there. Given your passions. And so I applied to and got accepted to the University of Pittsburgh, where I enrolled in the Au.D program and was working there. And sometime during my second year of the program, Catherine Palmer came up to me and said, the questions that you ask are not necessarily typical of a clinician. Have you ever considered a Ph.D? And I said, absolutely not. And then as I started thinking about it, I thought that would be something that I would be interested in. And the reason I said no is because my experience with research had been laboratory. And I didn't realize there was a whole area of research that actually was with your patients and not just bringing people in, but actual clinically based research that actually could change daily clinical function and not just, maybe understanding a neurology or understanding hair cells. And so once kind of talking with Catherine Palmer through what a PhD would look like and what that kind of would do, that really is something that I settled on. So I finished my third year of my Au.D program and started my fourth year at the VA in Pittsburgh, which I absolutely loved. And then kind of started doing my PhD work there. I graduated with my Au.D and stayed on clinically at the VA in Pittsburgh, continued to see patients, also worked in Sheila Pratt's research lab, looking at some different areas of perception, and then also getting my PhD. During that time, I also met my husband and we got married, and my husband was in Afghanistan, and my husband was hit with an explosive when in Afghanistan. And he came back and he really struggled to hear. So me being the audiologist I am, I tested him and he had perfectly normal hearing. And so, that was kind of when I had taken the information that I was really interested in from doing my PhD work. So my PhD work was on that kind of cognition and dementia, which I found very interesting. How does the diagnosis of dementia help or not help someone with, hearing loss and dementia, and where those two things dovetail together. But not only that, but then how does the, maybe a TBI affect that as well? So when I tested Kyle's hearing, he had perfectly normal hearing. And so that then left me to think, well, what happened? And so with Sheila Pratt, she wrote a VA grant and we started some TBI research. So I was doing both some cognitive research there and then also some TBI research. And that's kind of where I've fallen into. I'm really interested in how we can ensure that our devices that we're fitting on people, because I really love hearing aids. I really love, that technology piece, which is why I love audiology so much, right? we get the technology, the rehab, and the people.
Yeah.
And so, but I'm really interested in how can we take all of that information that we know about hearing aids and really make it individualized for our patients. And, whether they have a dementia, whether they have TBI, whether they're, a professional working in different situations. So I got my PhD and, really said, I really want to make, this difference in students and our future in our profession, and also still do some research. So I was really looking for a position that allowed me to teach and do research and do clinic. And so I ended up at the University of South Dakota. I've been at the university for 10 years, and I am now the chair of the department and the clinic director there at the University of South Dakota. So that's how I ended up where I am.
Love it. I got a bunch of questions and little asides. So first of all, it's really funny you mentioned the whole SLP thing, because that has kind of almost become a recurring joke on the podcast, is when I ask people what's the motivation, I would say like 80% of the time I've asked that question, both on the podcast and off, is like I was pursuing SLP or communication disorders, and then I kind of stumbled into audiology. So you are in the minority of people that don't fit that bill.
Absolutely. Now, ironically, at this point, as being the chair, I'm the chair of both an audiology and a speech language pathology program. And so I understand the speech language pathology, but that was just never something that I wanted to pursue.
Okay, so the other thing I was curious about, you said that you're at Washington State and they're like, you need to go to Pittsburgh. What was the connection there? What was the indication that you were giving off that like led your mentors or your professors or whoever at the time to point you toward Pittsburgh, and why?
Yeah. So the chair of the department at the time in Washington was a gentleman named Chris, and he is an SLP, but he previously had been at Pittsburgh. And so he knew that kind of my interest in this intersection, and he now says, I always knew you were going to be a researcher. He now, I'm like, yeah, okay. But he sent me there because my interests were kind of in that like patient interaction, and he knew Catherine. And so really he wanted me to go work with Catherine and Elaine Moore. And he said, these two people will really shape your profession. And I mean, he was not wrong. He really said they could really help you become what he knew I would do.
Okay, so that's interesting. Catherine Palmer once again makes an appearance on the podcast. When I interviewed Lori Zatelli not long ago, that there was a lot of love for Catherine on that episode too. She's got a lot of
definitely she is definitely an amazing human, and has really had an impact on my life. And her children I think of as nephews, and her whole family is pretty amazing.
So you go to the University of Pittsburgh. That's where you start your AUD work. And then what was that portion of time like when you were at the VA?
So I really enjoyed the VA. I enjoyed, there's a really great group of audiologists there. I realized the VA has some pretty high standards in how they fit hearing aids and their protocols. And, at the time, Richard Wilson and now Rachel McCardle are really, holding that VA, saying like, these patients really deserve the highest quality of care. And I really enjoyed seeing that part of it. I really enjoyed how the VA, really implements some of that nationwide. At the same time, I also started realizing that not everyone does that, and gives audiologists the equipment and the space and the time to provide that care. And so, started realizing that those kinds of things are really important. I also continue to see patients during my PhD, and I thought that was really important for me because, when talking with students and they have to do ground rounds, they're like, I want to find the most unique case. And what I try to say is every patient is unique. Every patient is interesting. Every single, has some nuance to them that you can help them in ensuring that they reach their highest quality of life. And I think that's what the VA really taught me, a lot of, and there's, they also have a huge repertoire of data, but, people think this is just, the average adult white male veteran. I'm like, yes, but like, I think that looking at them as individuals and not just the next name really helped me shape who I am. Also at the time doing the research and really helping Sheila move forward the TBI grant and really feeling like I could make a difference in some of these young veterans, and specifically my parent, my husband at the time.
Yeah.
Well, he's still my husband, but at the time him, having come back from war, transitioning out of the military and how we can help him made me feel like I was making a difference in my personal life as well.
That's really cool. So, when you say that Catherine really was like pushing you to pursue the Ph.D., it's already a significant undertaking to pursue your master's in the Au.D program and all that, but to take it a step further and go the Ph.D route, what was the moment for you that I guess like crystallized in your head that this was the right call? Were you sort of reluctant to do so initially, and like if so, what pushed you over the edge?
I think that it was really that initially I was reluctant, like this is what I was going to do. I was going to be a clinician all day and I love it. And I think one of the things that I was really super reluctant about is researchers typically don't see patients, and I still wanted to have that personal connection. But after realizing that, you can still see patients and the research that you could do could really have that initial impact on people was really important to me. My previous experience with research was great, but it was in the lab. We didn't really, we had lab meetings, we had lab notebooks, we had these weekly meetings that didn't feel like I was pushing the boundaries. But on the other hand, I've always enjoyed seeing, my parents will tell you, I always pushed the boundaries, right? I went right to the edge and just kind of step my toe right, just how far over the edge can I go? And that's kind of been my whole life. So I think that's what interested me about it. And then realizing that I didn't have to get an NIH grant. I didn't have to do that because on a personal side, I didn't want that publish and perish and get grants and grants and grants and, being that constant stress. I didn't want that because I was already working through with my husband PTSD and his, things and having that relationship was also super important to me. But once I kind of realized what a researcher could fulfill what I wanted, but I also could make it look like I wanted, was when I finally jumped in.
Okay, that's really interesting. So was the PhD dissertation that you wrote around the work that you were doing around traumatic brain injury and hearing loss, or?
No, so actually, I kind of started my PhD before my husband was hit with an explosive, and at how our lives influence us. My grandmother had pretty significant dementia.
Okay.
And so we moved her into an assisted living facility, and I was at my parents' house visiting her and realizing that is it possible that she's not following the conversation because she just is not following the conversation auditorily, as opposed to, actually not remembering what was being said. Mm-hmm. And so, I kind of started thinking gosh, dementia is just such a weird thing in general, and people are scared of it. How can we, really ensure that people stay connected and cognitive? And so actually that's what my dissertation is on. It's I was really interested in kind of that overlap of dementia and hearing loss. And then I realized there's very little research on that in general.
Yeah.
So then I started taking a step back and be how do we even diagnose people with dementia? Mm-hmm. And so I realized that okay, well, let me go do some research in that. And we go diagnose people with dementia with an auditory presented test. And well, that's clearly going to have an issue. And so if we present people with an auditory presented test, how does this hearing loss affect that? So that was actually my dissertation, was looking at one of the most commonly presented tests of cognition and running it through some hearing losses. And then I gave it to a bunch of 18-year-olds, college students with, in theory, perfectly normal cognition, and they showed up as having dementia. So, that was my dissertation, was looking at kind of how hearing loss can overlay even just the diagnosis of dementia.
Interesting. Yeah, I want to get more into that whole area because I know you're very passionate about it and very knowledgeable. But it's it's one of the many hot topics right now that I think gives me a lot of optimism about like the role of audiology into the future. I think this whole connection between the brain and the ear has been something that, as professionals have known for a long time, is obviously there. But as we learn more about this whole dynamic between the two, I just find it to be fascinating. And it seems like it's going to just unlock a lot of more need for professionals, I think, for like
Absolutely.
this type of audiologist or this role of audiology.
And I think, there are things that we get, that we know. I think that in some places, they're using it as a scare tactic. I mean, I was giving a talk in Birmingham, Alabama, and I was driving in a cab, and there was a big, huge sign, and it said, "Get hearing aids or get dementia." And I was like, well, I mean, like I didn't know. But I mean, it might, so I think that there are a lot of ways that people can take it. I don't think necessarily that's the best way, but, I think that in general, like, we can, that it is a huge area, especially with our aging population. And people are scared of getting dementia.
Yeah. I remember I saw a talk where one of the things that really stood out to me was that in terms of like, I think it was some sort of survey that they polled a bunch of people, or maybe it was just older adults. And it was like it was a whole lot of different scary things, from cancer to dementia to, you name it. And I think dementia was like number one of the thing that people were most fearful of. So it's clearly, I'm with you though, that I don't think the right approach is to just fear monger and say, get hearing aids or get dementia. That's probably not the right approach. But I do think that it's kind of a fine line that you have to walk, because you want there to be like some sense of urgency and take this serious. And in that regard, I think that bodes well for audiology, that, this whole notion that like hearing loss isn't some isolated thing. It's actually probably linked to a whole bunch of other things. Like when we were just in Minnesota and, Victor Bray had his presentation in the morning, and he's talking about metabolic health and, the links of the comorbidities. I mean, a lot of that was news to me. I didn't know that, like the kidney specialist, nephrologist would be actually, there's some interplay there between if you, are showing up as having sudden hearing loss, that there's a really large link between kidney failure. And so I found that to just be very interesting as this all kind of continues to unroll and we continue to find all these links. To me, it just screams like audiology has a seat at this like big table of like the interdisciplinary linkage between all these different things and what we can learn from all these things. And the idea that, man, maybe one of the big roles of audiology into the future is like, kind of a first responder of sorts, where you're one of the first to detect some of these major red flags that mean
absolutely
much more than, just something in isolation.
Absolutely. I think that this all comes down to, we are not just the ears. We are an ear. We are hearing on a body, right? And the people are, everything is interconnected. And, but at the end also, we want our patients to be able to hear their doctors, yes, like the ears can predict a ton of things. And I will always say that, especially when we're thinking about dementia, I see my patients a lot more often than they see their primary care doctor. So a lot of times I'm seeing cognitive decline even before their, physicians do. And what we're asking our patients to do is pretty detailed, like we're asking them to do a thing. The physicians are always trying to do these tests, which are incredibly important. Standardized tests are incredibly important, but we're asking them to do a task. And we actually can see them do this task. And if we see them decline in the ability to do that task, it's our responsibility to send them on to the appropriate referral sources. But we are fitting the whole body. On the other hand, we also want to make sure that they can hear at their doctor's appointments so that they can follow their doctor's instructions.
Yeah.
So I think we kind of have both. We kind of have both sides of that.
Yeah. Well, yeah. I mean, like that's another really, it's another big thing that, just having some sort of amplification in the, physician's room could go a really long way. And I feel like those are kind of things that are like mildly dismissed as being, what a great opportunity again for audiology to build inroads with the broader medical community, like writ large, is, going back to the conversation I had with Lori, we talked a lot about like, what she's doing around interventional audiology and working with occupational therapists. And the thing that really stood out to me about that conversation was you can like maximize your overall impact and your reach by enlisting other medical professionals to be advocates on your behalf. Like,
Absolutely.
having the nurse practitioner or the occupational therapist being very well aware of the role of having some sort of amplification in these settings and the value of having that. And like, then suddenly you have all of these other medical professionals that are in so many other settings that the audiologist could never really be in. So that kind of stuff to me is like, it just again screams opportunity,
Absolutely.
and just a way for, I think, audiology to elevate themselves in the standing in the recognition of who they really are and like the role they play with the broader medical community.
100%. So Lori, is one of my friends, and she's amazing, and they're in a hospital system, and I'm not, right? So we have a campus clinic, and we kind of run it somewhat more like a private practice. And so one of the things that we have done is gone out into our community, into our physicians, and provided some pocket talkers, or that's just saying Kleenex. I know
Kleenex, yeah, exactly.
But what we did is we put a sticker on them that said provided by the USD Speech Language and Hearing Clinic, and I think that that's a marketing strategy.
Totally.
And, that, and when I marketed it to those physicians, I yes, it's for the patient, but I actually talked about how it was for the physician, right? You're not using as much effort to try and, repeat the things over and over and over again, right? Like, if you market it towards them and how it will benefit them, they're more likely to use it. Then every time they see it, they see our name on it. Like we put a little, the things that go on the back of your cell phone that have, you can put your credit card in.
Oh, yeah.
The pop thing, but like what we did is we put those on there, and we actually stuck some of our business cards in there. Like, there are all kinds of marketing things that you can do to your local physicians. Yeah, we just got like the little credit card stickies and put some of our business cards. And so, in theory, if they feel like they're with a patient that needs to use this pocket, this pocket talker, then they hand them one of our business cards too.
Yeah.
I think that those are the kinds of things that you can do. But, going out to that, like, we need to help the broader community. We want these patients to be able to hear in their doctor's appointments.
Totally. So I think that you're like in an interesting, you have an interesting Venn diagram to the way you operate. So you are a Ph.D. academic researcher, but you're also a practicing clinician. And I know that when we were talking beforehand, you said that that's part of what led you to South Dakota, was the ability to kind of operate in all these different worlds. So how did the move to South Dakota kind of come to be? And was that largely the motivator, was that you could wear these different hats simultaneously?
100% that was the motivator. Looking at positions, do I want to, I didn't do a postdoc. So do I go do a postdoc? Do I go to a university and, with the intent of, okay, I'm going to really, move forward this, hard research line. And I just realized I wasn't willing to let go of the patients. I'd seen patients all through my PhD program. I was still seeing patients at the VA, and I really wasn't willing to let that go. And so, although in some ways it makes my life more chaotic, I'm still dealing with the patient phone calls and those kinds of things. Insurance and billing and those things. I really was passionate in that I wanted to teach in an Au.D program, but also and bring current research and things to the audiologist and the future audiologist. But I also wanted to be able to have some, authority with what I say and some realism and say like, hey, yes, there are these 57 things during an appointment that like we probably could be doing, but you can only do 5 of them because you have this amount of time.
Right.
And I think that it justifies a lot of when I tell people you should be doing these things in clinic, I'm actually doing them.
Right.
And I don't have a 3-hour hearing aid appointment.
Mm-hmm.
I have the same kind of appointment that you do.
It's good though, because you're grounded in the reality of it. Like, I think that's actually really important, is that sometimes it can be, if you're just working in theoretical land, to your point, you might find yourself in a situation where in reality and practicality, can you actually perform all of these best practices or do, it's like it grounds you in reality a little bit, which I think is probably it like I can see how these two work in tandem, where it informs what's realistic within your researching and vice versa.
Yeah. And as I go to give, talks, and as I go to talk to audiologists, one of the first things I say is, who am I?
Mm-hmm.
Like I'm running this practice. I'm, teaching students, I'm doing research, but you know what? I'm still seeing patients.
Yeah.
And I still tell the stories of on Tuesday when I saw this patient, this is what happened, or, those kinds of things. I think just gives a lot of validity and a lot of respect from clinicians when I'm saying these are the things you should do. I'm not just saying it from a theoretical perspective.
100%. So you just mentioned there, when you go, you travel, you talk, you're on the road right now, you're a bit of a road dog. You've been touring the country. It's like a bunch of different talks that you've been giving. So you want to just share about what you're speaking about? What are the kinds of things that you're really passionate about right now that you're presenting on?
It's a really good question. And part of this is when a state organization or a group asks me to come and talk, one of the first things I'm going to say is, what's important to your members, what's important to what you guys do. And I'm not giving a keynote speech. I never give like the same talk at the same place. And so I think that that's something that, I really am trying to tailor the things to the people for whom, are in this meeting. So, one of the things that I'm passionate about is verification. But, how I talk about that verification is different depending upon who I'm talking to. I may talk about the theory and why it's important. I could talk about the billing part of it and how, how do you bill for those services? How do you fit those into your practice? How do you market them? I think that that's kind of what I've been talking a lot about is verification of hearing aids. How do we set ourselves apart from over-the-counter hearing aids? And I think that that's one of the reasons that I'm kind of right now on a circuit is that, over-the-counter hearing aids are here and they're available. And so, I'm not worried about them. But one of the reasons I'm not worried about them is I am not the widget. Right. And how do we set ourselves apart from that widget is, providing the care, the individualized care, not a pull something off the shelf, read the instructions, that we provide that individualized care for our patients through verification, through validation, through assessing their needs. And that's more what I've been talking about.
Yeah, because like this whole theme has been, I would say like this is probably one of the biggest macro themes on the podcast to date is the notion of you're not a widget. And so therefore, how do you package your value, if you will, in a realistic way, in a way that is meaningful to, the potential patients that you could be seeing. And I just think that, like, for me, OTC really just sort of embodies the commoditization of the widget. Like, the days of there being a gatekeeper of, like, you can only get that kind of device, that medical grade device, through a professional. And today, even with OTC hearing aids, there's a fine line between, over-the-counter and clinical prescription hearing aids. But I think that the broader point remains, which is like, how do you actually justify people coming and seeing you. And for me, it's like, if you have a doctoral level degree like an AUD, then that in and of itself is a massive differentiator. But it's really just a matter of figuring out how do you like position that as being a differentiator rather than just assuming that the patient will know, especially in today's times when you have, big box retailers that have lower cost devices. So if you're a patient, you're sort of in a position where you have to make a decision. Do I go this route or do I go this route? And if over here is you as the private practitioner or whatever, how do you justify the premium that you're going to be charging or something like that? And so for me, it's like verification, real ear measurements, things that are best practices that can truly differentiate that patient experience seem like a no-brainer. Even more so pronounced, I think, in the OTC era, because it's just more obvious in the sense that that's going to be, you have to find ways for your services in that experience of you as the provider being differentiated. And so it's like, how do you square that? Because it seems like this should be something that is universal across the board. And so I'm curious, like, to get your sense of, why isn't real ear, for example, a universal standard within this profession?
I laugh about it with Catherine about, like, we just keep talking about it, and I hope that I'm moving the needle some.
Mm-hmm.
I had a patient come to me and he made the comment, and I think it's a great descriptor. He said, I can hurt my arm and I can go to the pharmacy and I can buy a sling. I can walk around with a sling on.
Yep.
But it may not fix the actual problem until I go to the doctor and the orthopedic and they actually do whatever they can do, some physical therapy, a cast, those kinds of things. And that's the differentiator, and he saw that, right? Like, another great, I think that the airline industry has done a pretty good job of this as well. You have your airline and, you have your airlines that are less expensive and they don't provide you even have to pay for water, when you're on that flight, right? Yeah. Those kinds of things, but you
bring your own lawn chair.
Yeah, exactly. Bring your own lawn chair, lock it in. But I think we know that, but when they first came out, we didn't know that these airlines were so much less expensive because, there's no padding on those seats. You're not going to get the comfort of your airline. And so when they first came out, we didn't know that. And now, as the years have gone by, those airlines are still there, but they have not disrupted the market of Delta, United, American. Like, they have not disrupted the market as much as I think that we're worried at first.
Right. And maybe they've just simply grown the market.
And maybe they've grown the market. Exactly. Right. Like, that what you're doing is you're giving people the opportunity to, start flying. And now they can, it's not as bad as I worry as much as I thought. And now I'm going to go travel internationally and go to somewhere like, Europe on Delta. Those are the kinds of things that we have to think about. And so that's kind of where our market sits. And how do we differentiate ourselves? I really do think that real ear measurements are one of those things, right? Like, we're not just pulling it off the shelf and handing it to the patient and saying, so how does it sound?
Mm-hmm.
Right? We're not, we're not a direct to consumer product that's calling the patient being like, how are things going? How are things going? Yes, that is incredibly important. But I knew that the product that I gave them was fit for them.
Yeah.
And sometimes I have to push my patients. You're paying for every single one of these sounds. So I can turn it down, but you've paid for this sound, and having them believe my expertise. I think that my patients see me for a reason, and it has a small part to do with that. I help them select the right product, but more having to do with they know that if something were to go wrong, I'm there to help. If they, but they also know that they're getting the most out of the product that they purchased.
Yes.
And that's what I feel like, where real ear measurements start is we are providing them everything that this product can do. I've selected the level of, I've helped them select the level of technology that's most important, that they're getting the most out of their thousands of dollars.
Yeah, totally. And I think making them aware of what you're doing, that like I'm performing this real-ear measurement, which is just a great way for whether, like the speech mapping, and showing them like, I'm basically tuning your hearing aid in a way. I don't know. It just seems like those are the kinds of things where people will walk away from feeling like that the premium that they paid was justified. It's as simple as that. And obviously there's like a continuum of care, like the idea would be that this is the first of many subsequent appointments, and that, these are your patients for life kind of thing. But I kind of think that it's about how do you like ensure that you get people in the door initially, and that, for the people that haven't even contacted you before, there's at least a surface level understanding of why you're different. And I do think that like Real Ear is a really good example of something that you could do that is just a way to differentiate yourself on the basis of best practices, or however you want. It's not like a silver bullet, but it's an obvious thing that I think resonates with people, that they will understand that. I mean, again, it's like using OTC as a way to, juxtapose it basically and say, you can get something that's truly out of the box, one size fits all, where you can come to the professional, and along with me being your medical professional, I'm going to tailor this thing to you. So anyway, it seems like a great way to differentiate yourself.
Absolutely. And I think, we also are the medical professional, just as you said, which is, if someone has a sudden hearing loss, or, I had a patient a couple of weeks ago that told me that she had really bad tinnitus, and when she pushed on her jugular, her tinnitus went away. And so that was quite concerning. So I pushed her to the ear, nose, and throat physician, that I am still part of your overall health, right? Like, I'm not just selling you a product. I am ensuring that your overall health is still in the forefront of my mind. I had a patient on this week who I saw, who, I did my case. She's brand new to us. I did my case history. She's worn hearing aids for a really long time. And then I always end my case history with, is there anything you want to tell me that you don't think that I've asked? That's how I always end my case history section. And she asked me if there was any kind of vibration on her wrist that could be an alarm clock. And I kind of paused for a minute, and then actually kind of took a step back, and we started talking about how does she wake up in the morning, and those things, and I think that having, those kinds of conversations. She said, I've been to seeing audiologists my whole life, and no one's really talked to me about these kinds of things, and actually she hadn't been seeing audiologists. She'd been seeing not audiologists.
Yeah.
But, I think that part of our healthcare is we are the whole person.
Yeah.
But coming back to Real Ear is, I know that product that I'm selling is providing them everything that they're purchasing.
Totally. So to change gears a little bit, going back to your husband and the whole work around the TBI and all that, like, what did you learn? That's really interesting that you said that the initial audiogram came back and that apparently he has perfectly fine hearing. But again, this is another sort of portion of audiology that fascinates me, is like the pure tone audiogram is like just one clue, and sometimes it's
one
not
piece.
Even it's one piece of the bigger puzzle. And I'm learning a lot about all the different kinds of jigsaw pieces that you can sort of, extract from your patient. So this one's really interesting. So kind of like walking through what you guys learned.
Yeah. So, when we're in school and we're learning how to do tests, who do we always do them on? Our friends and family. And so, I was learning about auditory processing disorder, and he was my boyfriend at the time, and I put him through an entire auditory processing battery. And he was like, yeah, okay, this is fine. Well, then, he went to Afghanistan, and some things happened, and he came back, and he has these problems, and I put him in the booth, and he has perfectly normal hearing. And then I put him through that CAPD battery again, and he had completely different results. And so, like, that was really, eye-opening to me, is that what is the effects of blast exposure? And so, one of the things is looking at, that change. And I think we talk a lot about sudden hearing loss and the emotional effect of that change. We've been talking about auditory processing disorder for a long time in children.
Yeah.
But what about that change? And so that's the other thing that I keep kind of coming back to is, this started in this blast and what do we do? And, my husband got out of the military and decided to go to school. Well, he was struggling in the classroom. So I actually fit in with hearing aids. And, I fit in with some high frequency gain hearing aids and an FM system. And he was very successful in school after getting that input, right? Talking about signal to noise ratio. And that's part of when I keep saying, like, we got to think about the whole patient. Now, we've been talking about this from like the veteran blast exposed, which I really do think, is a big focus of the VA. Obviously, the data say now, like, it basically, if someone can make it off if they get injured and they can make it off the out of theater, they're going to survive. And so we're now dealing with some of these bigger complications when they come back. And so, some of them we can see, my brother lost his leg, those kinds of things. But, once we, some of the other things we can't see and we're getting better at PTSD and this TBI. And so we are seeing it in the veterans and we're focusing it on the veterans, but there's a lot of other populations. We talk about football players, okay, but also car accidents. And then one other group that I've really been thinking a lot about are domestic violence survivors. And how it's not something I'm going to necessarily bring up in an appointment, but when we see someone who, may be struggling a little bit more than we would have anticipated, or, is, one of those things about providing appropriate amplification is in improving signal to noise ratio. And improving signal to noise ratio is so critical, but it's possible that these people are domestic violence survivors, which is a traumatic brain injury. And just not something I had really thought about when I'm thinking about, this TBI people and my husband, and we, hear about it and we see it in veterans. There are other populations for whom this is incredibly important as well.
So just kind of as somebody that is not nearly as well versed in this space as you are, how can I be thinking about this in terms of what's going on there, where a blast makes sense for me? And the concussion piece is making more and more sense to me as I learn more about it. And audiology's role is super interesting in that, given the type of specialty equipment that is in this space and how you might be able to diagnose. But for something like, domestic abuse, I'm trying to understand what the link is there with, it seems like, to your point, it's around something bad is going on with your brain, and that one of the byproducts of that could be, something about the way in which sound is processed or something like that. So, just like trauma in general, is it just the way that the brain is like wounded and then how it's healing itself, and then, the ways in which your body's responding to that, and how something like the ways in which you process auditory or audio, that could be impaired. I'm just trying to kind of better understand this.
So I don't know if you remember when I said that my undergraduate was focused on neurology. I think that's one of the reasons that I find this so interesting, because it comes back to that like neurology side of me. As with injury or anything like that, we do know that some of that neural mechanisms form back. They don't form back the same way. So simple tasks like raising your hand when you hear the beep are just fine. But, being able to perform in difficult listening situations, being able to suppress one signal while attending to another signal is really where we start to see things, differentiate. And that is one of the things where providing appropriate amplification, especially in those high frequencies, are really helpful. Right? High frequencies are typically, yes, where people have hearing loss, but in English is also where a lot of contextual cues are, knowledge of, is this a question or is it a statement? Because it goes up at the end or down or flat. All of those things, a lot of those things occur in those high frequencies. And so ensuring that people are hearing all of those sounds and making sure that it's audible is really important for them, because they can't do the things necessarily like suppress the low frequency sounds of noise. Additionally, technologies of being able to perform, directional microphones and how those technologies actually help people is the other way that we can differentiate from some of those OTCs, making people aware how those technologies work. But also when we think about things like TBI, when we're relating it to blast exposure or domestic violence, is those overlap with PTSD. And part of this is that it's really hard to separate those two, because the awareness of their environment is part of that PTSD. And so being able to say, I promise you that these hearing aids are providing you the audibility that you need to be able to hear everything around you, or at least peripherally hear that, so that then your brain can figure out what to do with that information, has been really settling, because I know that I am providing that. And I have documentation that my hearing aid is doing that. Additionally, I can document that this hearing aid is not going to hurt your hearing, right? I've run my maximum power output. So I know that this hearing aid is also not going to hurt you. And so being able to have that documented is one way to not only just help our patients, but also protect ourselves in some of these situations that can be a little bit more tenuous.
Yeah, no, that makes a lot of sense. Okay. Well, thank you for walking me through that. So, as we kind of come to the close here, what's going on in, whether it's in your world at South Dakota or on the road with your speaking tours? We've talked about some of the different things that you're passionate about right now, but what does the remainder of 2023 look like for you? What are the things, the big picture things that you're really passionate about, both on like a individual personal level, but also macro for the industry as a whole? Like, what are the things that you feel strongly about that either we need to, get on the same page with, or something that you're really optimistic about just in general? Like, where's your head right now kind of with where either you personally or audiology as a whole stands and moving into the future?
I think that that's really interesting. I think many states are opening our state laws because of OTCs, right? Like, how are we going to, look at a rewrite it, kind of solidifying our role and what we're allowed to do in our licensure laws. And so I think that it's something that we should consider about adding verification into our licensure laws as we move forward, right? That we're providing appropriate or ensuring appropriate amplification with the devices that we see. I think that that's something that, I would hope as we move forward with our licensure, as many states are opening their licensure laws. I think that one of the things that I personally am moving toward is not just verifying that the hearing aids are functioning, but some of the features within the hearing aids, directional microphones. When we receive a hearing aid from a manufacturer, are we checking it in to make sure that it's doing the things? Hearing aids that are coming back from repair are not the hearing aid that we sent in, so we need to recheck those. That's something else that I am saying, like, where else can we make a difference, and not just when we fit a hearing aid, we're providing documentation of the audibility, but what other things do we need to be checking? And in the future, I see us being able to really push manufacturers to say, how do I verify the difference between the economy level and the high end levels? How do I know that the hearing aid is doing the thing that you tell me that it's doing? And so I think that that's one of the things that I'm really working on, is verifying some of those advanced features within hearing aids that will help us better select the level of technology that's most appropriate for our patients and their lifestyle.
Yeah, that's fantastic. And I know that this year's AAA, you'll once again be doing the verification lab. Is that correct?
That is correct. So the Wednesday morning before AAA starts, I'll be doing a learning lab, and it's about verifying advanced features. So we'll be talking about, maybe how do you verify an over-the-counter hearing aid? We're going to be talking about that. But then also, how do you verify some polar plot things? How do you verify frequency lowering? Things, the features within the hearing aids. How do we verify that they're actually functioning and we're not just checking the box, turning them on, and trusting the manufacturer? I always say trust them, but verify that that what we're getting in our hand is what they turned into the FDA.
100%. Just to go off a quick tangent, so with the OTC side of things, with that, where you can verify that, do you think there's much opportunity there? Where, like, do you envision a scenario where you could see consumers coming in with something that they bought and saying, this thing doesn't seem to be working the way that it was advertised, or something like that?
Well, so going off of, the University of Pittsburgh and Elaine Moore have a phenomenal thing that they have that is a relationship between pharmacists and audiologists, and kind of taking that model, we actually met with our Good Neighborhood Pharmacy, and we met with them, and they're phenomenal, and the local pharmacists, and we said, we will vet a hearing aid for you. We will tell you which OTC to carry. But when patients come to you and say, help me fit this device, here is my card. I want you to give them my card. And so that is kind of the relationship that we have with our pharmacists, because pharmacy is the only medical professional that you can see without an appointment.
Yeah.
And so, they come, patients are just going to them. Well, pharmacists are feeling like they don't really want much to do with this, right? They deal with medication. And so giving the pharmacist that avenue. So I do see this as an opportunity for us. We are not personally carrying an over-the-counter hearing aid. That doesn't mean that private practices can't.
Mm-hmm.
We are not personally doing that. But, if somebody comes to us with an over-the-counter hearing aid, we do have a protocol on how we are verifying that device works. And it's really just very simply the similar to what a hearing aid, we put a probe in their ear, and we have their hearing test, and we know what that device is doing. And then we're giving that patient advice as to how to utilize that OTC. And when that device is no longer meeting their needs, that they can come back to us for advice on what to do next.
Yeah, I love that. I really like the proactive approach too, to go and seek out, the pharmacy. I mean, that to me seems like a really positive opportunity is, if you don't want to be the one that's actually going to dispense or facilitate, the OTC fitting or whatever, like at least you can still point them in a certain direction. And maybe you can build, some sort of mutual relationship where they're kicking up the people that do actually really warrant that moderate to severe, profound hearing loss level of care. So, I mean, this whole OTC space is like, it still feels very much like the Wild West. I don't know totally how the professional channel is going to be involved with it. Like, I don't know if it will always just sort of be on this like next level up plane, or if there will actually be a real role for them in that space. It just, for me, it's kind of yet to be seen. But I think the moral of the story, what I gathered from you, is that, it's like you can still be involved in this all by positioning yourself as the expert.
Absolutely. And, we have Market Track, and, if you want to read about Market Track 2022, the seminars and hearing from 2022 is available for anybody to read. It's open source. And so that's the US data, but there's also the Japan track. There's also Euro tracks, by the way, but Japan track, one of the things that I was reading about in the Japan track is they've had an over-the-counter hearing aid for about a decade. And so you can actually kind of think that could be a predictor to demonstrate what the OTC market will be here in the United States. And it's had very little disruption on the actual market, kind of back to what we were saying about once people realize what they got out of the basic hearing aid, airline, whatever, then people are choosing where to go based upon their personal need.
100%. Yeah, I mean, it could, for all we know, for me, the big question is this a new market? Are these people that aren't even in the funnel at all, or is this part of just bridging that 7 to 10 year gap? Is there going to be cannibalization? Like, will there actually be people that were prescription grade hearing aid candidates that went the OTC route? I'm sure there will be some of that, but
sure,
I'm not convinced in any way that this is going to really impact the market that has historically been served by the medical channel. To your point, maybe that airline analogy is actually really spot on, where it's just kind of like a budget tier that might be the place that people begin. They get their first experience with, and then they graduate into something that they realize what they paid for, like you said, and then they move into the actual professional channel down the line. Who knows? But I think, again, the number one thing I think that you can take away from it is, like, regardless of what happens in that space, you just differentiate by finding ways to communicate to the market of the kind of experience they're going to receive from you. And if you're an audiologist, I think that means it's going to be something that adheres to the kinds of best practices that you are capable of providing, like verification.
Absolutely. And I think that really differentiating our market is what will continue to be what sells us as a profession and keeps our profession in the top of the mind of the physicians, of the patients, of the pharmacists, of the community, when they really actually want the holistic care and not just the widget.
100%. Well, Lindsey, this has been an awesome conversation. I really appreciate you coming on the show today. This has been a lot of fun.
Thank you so much for having me. Have a great day.
Absolutely. Take care, everybody. Bye-bye.